Limb and ventral edema in horse. We will focus on one of the most visible signs of equine systemic or localized illness, swelling of the limb or belly. We will begin with the discussion of fluid dynamics, specifically how alteration in Starling forces result in edema, whether it's increased hydrostatic pressure in congestive heart failure or reduced oncotic pressure due to protein loss. Understanding the pathophysiology is essential. We'll review the clinical presentation of common conditions like cellulitis, lymphangitis, and vasculitis, how to distinguish them based on symmetry, heat, pain, and systemic signs. A key takeaway today is your diagnostic approach. Always integrate history like transport or trauma, physical exam finding, and target diagnostic like ultrasound or blood work. Finally, we will go over treatment from anti-inflammatories, antimicrobial to bandaging and exercise, and how to guide owner on prognosis recurrent prevention. And the ventral edema in horses. Edema by definition refers to the accumulation of fluid in interstitial space. In horses, it commonly affects the limbs and the ventral abdomen and can be localized or generalized. Pathophysiology. Edema results from imbalance in hydrostatic pressure, increase in congestive heart failure, oncotic pressure, decrease in hypoproteinemia, capillary permeability, increase in vascularity because of infection, maybe lymphatic drainage, decrease in lymphangitis or fibrosis. Common causes type: localized cellulitis, lymphangitis, trauma, insect bite; generalized right-sided heart failure, hypoalbuminemia, vasculitis, Purpura hemorrhagica, Neoplasia, Anemia, liver disease. Differential diagnosis: clinical signs: unilateral hot painful swelling, cellulitis and lymphangitis; bilateral limb edema with petechiation, vasculitis, Purpura hemorrhagica; ventral edema with muffled heart sound, pericardial effusion; ventral edema plus colic history, hypoproteinemia, protein losing enteropathy. Diagnostic approach: history, transport, wound, systemic illness; physical exam, check for heart, check for heat, pain, skin lesions; ultrasound, soft tissue inflammation, fluid pockets; blood work, CBC, TBA, albumin, fibrinogen, SAA; culture aspirate if abscess or cellulitis suspected. The treatment protocol: anti-inflammatories, non-steroidal anti-inflammatories, flanaxin or phenylbutazone; antibiotic, broad spectrum penicillin plus gentamicin; cold hosing, hydrotherapy, compression bandaging; diuretic, rarely indicated only in CHF related edema; exercise or controlled movement; treat underlying cause, cardiac disease or GIT loss. Prognosis: cellulitis can become chronic or recur; lymphangitis may lead to permanent scarring; generalized edema from hypoalbuminemia or cardiac failure has variable prognosis depending on the cause.